Hi, good afternoon to all of you. In this presentation, I would like to share with you the use of steroid for eye diseases in primary care setting, whether it's a friend or foe. Steroid prescription is very common and it comes with either systemic form for various diseases. And for eye diseases in primary care setting, it usually involves topical eye drops or ointment. And I will focus mostly on the topical medications in my discussion here. First of all, I will discuss about the general use of topical steroid, followed by the use of these medications in acute red eye, and then the potential ocular side effect. Last but not least, at the end, we will discuss how to make friends with these medications. Topical steroid come with various forms and types. It can solo in the form of the eye drop or ointment, or it can be a combination with the antibiotic. The common type of steroid used for the eye diseases are dexamethasone, prednisolone, fluorometalone, and also the loteprednol. As we all know, steroid is a very good treatment when you use it correctly because it's a very effective treatment for reduced inflammation. It is easily available in most of the healthcare setting. It's really cheap and economical friendly. And most of the time, it can combine with other medication like the antibiotic I mentioned just now. So we can use one medication to target different pathology. So the on-label indications for eye diseases for topical steroid are usually not infectious inflammation that affecting the anterior part of the eye. So usually used to target the allergy and also the inflammatory component inside your eye. In primary care setting, I believe usually used for the acute red eye due to the allergy reactions or viral conjunctivitis. In our setting, we usually use for the post-operative indications and also for treat for the uveitis as well. Now let's talk about the use of the topical steroid for acute red eye. The common causes of the acute red eye in primary care settings are conjunctivitis, blepharitis, allergy eye disease, and also sometimes they will come with you with the dry eye disease with the red eye, and also after a trauma with some epithelial erosions or foreign body red inside the eye. These are all the common causes that they will present initially to the primary setting first instead of go to the tertiary eye care setting. So you are very confident now that you are dealing with conjunctivitis, and most of the cases of the conjunctivitis are viral conjunctivitis. So the next question is whether you want to use the steroid for these patients. The use of steroid for conjunctivitis is controversial. Definitely can alleviate the inflammation, especially the symptoms. Patient can feel much more comfortable, but you have to be very careful regarding the infective component that potentially exists in the conjunctivitis, especially when you deal with the contact lens wearer, ocular trauma, and also pre-existing ocular surface disease, or they have an ocular surgery not long ago. The potential of the infective component can be outweigh the inflammatory component, and the use of the steroid is not advisable in this group of the patients. So you advise you just to use the topical artificial tears to relieve the symptoms. At the same time, you can add on a topical antibiotic as a prophylaxis to prevent the secondary infections. So here we'll talk briefly regarding the use of topical steroid for the acute red eye when they presented with the allergy eye disease, dry eye disease, and also the blepharitis. So allergy conjunctivitis, whether they are acute or chronic, the first line of treatment should always be a topical antihistamine, mast cell stabilizer, and also the artificial tears. In the chronic conjunctivitis, we can always add on the topical immunomodulator like cyclosporine. So short course of steroid will be very useful when they're presented with exacerbations and when presented with a very flare up of the red eye due to the conjunctivitis. But it should always limit to the 1 to 2 weeks course of this topical steroid use. So same go to moderate to severe dry as well. The short course of the steroid can be only used for the very beginning when they have an exacerbation of dry eye. The first eye is go back to the topical artificial tears, and also in certain cases when they are moderate to severe dry eye, we can add on the topical cyclosporine as well. So the alternative of cyclosporine as anti-inflammatory in the chronic conjunctivitis and also the dry eye disease will help you to prevent the complication of the steroid that we discuss later. So for blepharitis, basically there is no role in the use of the topical steroid. The main treatment will be a topical artificial tears and also the topical antibiotic to target the microorganism in your eyelid. The next commonest cause of acute eye presented to primary setting is after the eye trauma. So usually come in the form of corneal abrasions or foreign body when inside the eye. So first of all, definitely have to make sure that the foreign body is out from the eye. If you're not sure, then it will be better to refer to the eye doctor for sleep examinations. But the aim of the treatment is actually to promote the wound healing and also serve as a prophylaxis for secondary infections because the wound can be contaminated. So topical antibiotic and topical lubricants are the mainstay of the treatments and also the first-line treatments. Usually topical steroid considered as a contraindicated in this case because we all know that steroid actually will impair the wound healing. And in the context when the wound is not intact, the use of the steroid can actually aggravate the melting and also the atrophy of the tissue as well. After talking about the use and indication of the topical steroid in eye diseases in primary care setting, we now move forward to the danger part of the steroid, the side effect. All these side effects of glaucoma, cataract, infections, melting and atrophy of the tissue are all the well-known side effects. I believe all of us will be aware of the side effect here. The important point of here is not to avoid to use a steroid at all, is to know that when we need to use a steroid, we will know that what are the susceptible individuals to develop this kind of the side effect, and also we should prepare a individual monitoring mechanism for us to prevent the onset of this side effect, or be able to reverse the side effect before it's too late. So generally speaking, the side effect of the topical steroid usually develop after 7 or 10 days use is usually. Another principle is that the local administrations of the steroid, like topical steroid, can also develop systemic side effect, but it's very rarely. But you have to be very careful in the baby and also the children because they have relatively low body mass. So the systemic association may have a significant side effect to them, but not in the adult. On the other hand, systemic administration of the steroid, for example, your IV and also oral steroid, can also likely to have a local side effect in the eye, but the side effect is mainly on the cataract development instead of the glaucoma itself. So the local administration of the steroid, like topical steroid, definitely will be highly likely to have a local side effect, and also it largely depends on the exposures, for example, the dose and also the durations, versus the susceptibility of each individual. So the first side effect and complication, and I think is the most dangerous side effect that we are going to discuss now, is the steroid-induced glaucoma. So here are the few key questions that we need to bear in mind when we prescribe the topical steroid when we worry of the glaucoma. So the first question is who will develop steroid-induced glaucoma? Basically, the answer is everyone. Even though some of the individuals they are more susceptible to the development of the steroid-induced glaucoma, for example, glaucoma patients, but for those patients that without any risk factor, they can still develop glaucoma as well. So when will this steroid-induced glaucoma start to take actions and also happen? The answer is anytime. But usually it's within the first few weeks, for example, after the 10 days or also after the 2 weeks. But the intraocular pressure can be elevated within an hour, or it can be after many years of the chronic use of the topical steroid. The third question is, which type of the steroid is usually will induce the glaucoma, and the route of the use of the steroid as well. So the answer is any type and any route of the steroid can induce glaucoma. But definitely the potential to induce glaucoma is proportionally to the potency of the steroid. The more potent of the steroid and also the more penetrations of the topical steroid that you use, for example, dexamethasone and also the prednisolone, the potency to increase the intraocular pressure is much more compared to other less potency anti-inflammatory steroid, for example, loteprednol and also the FML. So ocular direct application like topical or injection inside the eye of the steroid definitely will be a higher risk compared to the systemic applications or the inhalation or also the nasal steroid. They are much more common in the topical, and I will consider as a very rarely happen in the systemic and inhalation or nasal steroid to develop a glaucoma. Another two key points to take notes is regarding the increase in the intraocular pressures. You wonder whether this increase in the intraocular pressure is reversible or not. In most of the cases, the intraocular pressure usually will be normalized after you stop the topical steroid, and usually will normalize within 1 to 4 weeks. But there are some cases that will become persistent, and also it depends on the duration of the use. When the duration getting longer and chronically used, even after stop the topical steroid, the high intraocular pressure can be persist. So another question is the damage that happened in the optic nerve because of the chronic high intraocular pressure, whether is it reversible or not. For this, unfortunately, is no. Is it always irreversible for the optic nerve damage? And also how fast the optic nerve damage can happen, it really depends on the degree of the elevated IOP, duration of the high IOP, and also the vulnerability of the optic nerve. So in the patients who have a very high cup to disc ratios, they are almost in advanced glaucoma. Any small increase in the intraocular pressures can hit them very hard. So, and another danger point of this optic nerve damage I mentioned is they're always painless, they're always progressive, irreversible, and at the end they will lead to the blindness. So as mentioned, it's very important for us to identify the at-risk group for those who will likely develop steroid-induced glaucoma. So here is the list of those who have an at-risk group. So in the extreme of the age, for very young patients, especially if they are less than 10 years old, and in the very old patients, highly likely they have a pre-existing glaucoma, or even they have only the family history of glaucoma. Another high-risk patients are they are high myopia, in case that they have very high power, or they have pre-existing disease of diabetic mellitus and also certain connective tissue disease, for example, rheumatoid arthritis. They bring them to the higher risk of the steroid-induced glaucoma. And definitely, dose and duration is actually one of the key points for development of the steroid-induced glaucoma. So in a general speaking, if the patient have none of these risks mentioned above, but if the use of the steroid is more than 10 days to 1 week, the monitor of the glaucoma development is a mandatory, and you need to refer them to the facility to able to check them for the intraocular pressures. For those who have the risk that mentioned here, the dose and durations will increase their risk, but you will need to monitor them even much closer. For those who have a very high risk patients, after starting of the glaucoma of the steroid medications, you need to close monitor them at least in a week time to make sure that their intraocular pressure not increase. So the next well-known side effect of topical steroid that we are going to talk is this, the cataract. As compared to the complication that we mentioned earlier, the glaucoma, the development of cataract by the use of steroid can due to both topical and also the systemic steroid. And also compared to a glaucoma, which is an irreversible damage when it hit the optic nerve, the cataract is always a reversible disease by the surgery. But you have to be very careful in the pediatric age group, also especially they are less than 10 years old. The development of the glaucoma from the very beginning of their age will actually induce an amblyopia. And this amblyopia, after the fully development of their visual functions after the 10 years old, will not be able to reverse well. Next, we will talk about the infections, especially infections that are aggravated by the steroid use. So the first principle is not to use the topical steroid in the uncontrolled infections. So first of all, we have to make sure that the red eye they come to you, whether they are infective versus not infective. So not infective like allergy, dry eye, and trauma as that we mentioned before. In case this is an infective red eye, use of the topical steroid can worsen the infections. It leads to the progressive ulcerations, melting, and also the perforation of the structures, either the conjunctiva, sclera, or even the cornea, and also lead to the progress of the infection inside the eye, lead to the endophthalmitis. The dangerous of this is this use of the steroid actually can mask the symptoms of the inflammation like pain and discomfort. So patient may feel relatively better, but the infection actually is worsened. The other problem is the use of steroid will lead to the atypical presentations. So when patient come back to us, we are unable to identify the microorganism based on the features as well as those without the steroid. Use of the steroid in the hepatic keratitis is another danger point because it will change your dendritic ulcer to a geographic ulcer. And most of the time, the patient from the beginning, they have a painless presentations because of the neurotrophic pathology of these virus infections. And this geographic ulcer, if left untreated, can lead to a cornea melting as well. Here come to the last section of our discussions, how to make friends with the topical steroid when we're dealing with the eye diseases. So first of all, we have to know the indication to use it, and also always try to consider an alternative before you use the steroid. Identify the risk factor as you mentioned just now. And very important thing is before initiate the steroid use in your patients, always counsel them to tell them the danger of the steroid. And important thing is they cannot use a self-prescription and also to continue the use of the steroid without informing you all. Another thing is have to make sure that you have a proper monitoring mechanism by taking account of the duration of the use and also the risk that we mentioned just now as well. And also say no to the steroid when you are dealing with undiagnosed red eye and you're dealing with patients that they're highly likely you have a self-prescription of the steroid. They just want to get the steroid from you. And also do not prescribe steroid when you have no chance to do a counseling and also the monitoring. It's not the initiation of the repeating of the topical steroid per se that put the patient at risk, but it's a failure to warn about the side effect and also the repeating of the prescriptions without reviewing the need of the steroid. So the slit lamp and also intraocular pressure examination is required for any patients who require a prescription of the topical steroid more than 10 days or any duration for a susceptible individual. And please always consider the alternative like topical antihistamine, topical mast cell stabilizer, and topical NSAIDs. And also not to start the steroid too early because it should be reserved for the progressive condition when the alternatives are less effective. So in a nutshell, when we prescribe steroid, first of all, we have to know the potential side effect, know the risk factor, know the alternative besides steroid, and know the monitoring mechanisms. And last but not the least, you have to convey what you know to your patients so your patient will understand this well and able to follow whatever you advise. I would like to thank you for your attention and thank you for the committee for giving me an opportunity to share with you all this topic. And again, I would like to thank all of you to take care of the eye together with us. And also, I think this will be involving a teamwork to provide the healthcare and also the eye care to the patients. Yeah, we welcome questions after these sections. Sharing here are the references for this talk. Thank you.